Our next speaker will talk about the vascular trauma surgery, an essential tool for improving battlefield casualty care. Our speaker is a lieutenant colonel from Russian Armed Forces Military Medical Service. He's a vascular and vascular trauma surgeon and assistant professor of surgery at Department of War Surgery, Kirov Military Medical Academy, Russia at St. Petersburg. He's a consultant trauma surgeon at DASAN-LA Research Institute of Emergency Medicine, lecturer and invited faculty at trauma workshop at Reva University in Sweden. His interest is on trauma surgery, vascular trauma, polytrauma, shock, damage control resuscitation, and damage control surgery. He's also inclined on visceral trauma, endovascular bleeding, and trauma management. He's a fellow of the Russian Society for Angiologists and Vascular Surgeons, European Society of Vascular and Vascular Surgery, at European Society for Trauma and Emergency Surgery, Ambro-Paré International Military Surgical Forum, and Russian Society for Surgery. Our next speaker is none other than Dr. Victor A. Reva.
Dear Chairman, dear colleagues, dear moderators, I'm very thankful for the invitation to have a speech at this fantastic event at ASEAN Collaboration for Trauma. I think this is a great initiative, and we are doing quite the same in my country, trying to develop new trauma techniques in the trauma world, in surgery. And my today talk is devoted to the Vascular Trauma Registry, an essential tool for improving battlefield casualty care. As I'm a military surgeon and I'm focusing on vascular surgery and vascular trauma, I'm trying to embrace not only trauma registry, because some people did more than me at this particular topic, but I will try to embrace it from the vision of a vascular surgeon, trauma surgeon, and military surgeon. So it started more than 10 years ago when Professor Samakvalov, my mentor and teacher, gave me the topic of my PhD thesis as a pre-hospital hemorrhage control. I started to investigate tourniquets, local hemostatic agents, dressings, etc., to save lives in the pre-hospital arena. And the next stage was my meet to Professor Rich in Helsinki in 2013, and few other meetings in the US and during MHSRS conference, and in Washington, the meeting organized by Mark Bower as the leader of Ambroise Paré International Military Surgical Forum at the moment. And I'm very thankful to him for that. And my meet to Dr. Rasmussen, fantastic conference organized in Azerbaijan as the first Congress, International Congress of the Society. And again, I was invited by Amila Ratnayake to Sri Lanka. It was a fantastic trip with my friend David McGreevy from Sweden. And in the picture you can see here with Kosova Samarante, he is an active leader now of the Ambroise Paré International Military Surgical Forum. All my materials were summarized during the talk, during the annual European Congress of Society for Vascular Surgery. That was a great event with the very long talk, 15 minutes talk summarizing our personal experience. I will not be focusing on the vascular technique itself, but we'll try to show what we have here in Russia, maybe to share something or to exchange knowledge and opinions. And I will try to focus on a few very important figures in our history of vascular surgery and vascular trauma, especially in aspect of military surgery. The first and the father of Russian surgery, Nikolai Pirogov, is a very famous surgeon who investigated a lot local hemostatic agents, tourniquets. He had a PhD thesis on ligation of zone 3 aorta, as we could say today. It's a level of above aortic bifurcation. He investigated what's going on after occlusion of aortic bifurcation. He investigated collateral circulation and found some important data which laid down as a basis for future research performed by our surgeons and surgeons in different countries. His follower, Vladimir Opel, who was the chief of our academy and founder of Department of War Surgery, where I work at, and he proposed epinephrectomy, ligation of concomitant vein and arterial injury, and also investigated collateral circulation. Due to efforts of Todd Rasmussen, we published a paper in Journal of Trauma a few years ago about him, and he's a true leader and very respected surgeon in my reality. The next one is Nikolai Korotkov. He was also investigating collateral circulation. He volunteered participating in 2 wars and trying to auscultate traumatic pseudoaneurysms, and found the sounds that were called Korotkov sounds, and now they have his name. And he was a student and worker at the Military Medical Academy, trying to investigate this very new topic in the field in military surgery. But he investigated not only military and vascular surgery, but also in cardiology and medicine in whole. Justin Janelidze, who sutured ascending aortic injury for the first time in the world. Boris Petrovsky, who was a friend of Michael DeBakey and organized care at the theater of war, World War II, doing many vascular repairs, vascular reconstructions, as many as he could. However, we know that the main operation at the time was arterial ligation, and he probably he is a founder of vascular surgery in Russia. Vadim Kornilov, who proposed the first classification of acute traumatic limb ischemia, very simple, 3 categories, as now we know as Rutherford classification: viable, threatened, and irreversible. Kornilov proposed many years before Rutherford compensated, uncompensated, and irreversible, with the same parameters to define the certain level of ischemia. And the only non-military surgeon, Nikolai Volodovich, but who contributed most, not only to vascular surgery, all the conferences in vascular world now are using his technique. He was the first who described stent graft implantation, and the first stent graft he created in 1985, first implant a few years before Juan Parodi. And by the way, the first implanted graft was into thoracic aortic injury, not acute. It was chronic thoracic aortic pseudoaneurysm, very big one, and that was the first paper on the topic. But before the beginning, I would quote one of the Russian imperial botanists and physiologists, very known in Russia, Clement Timorazev, who recommended to know a little about everything and to know everything about a little. I would say that this is a motto of a modern war surgeon, and to be that the war surgeon should be good at trauma surgery and be perfect in vascular surgery. This is my vision, and as I know, vision of many experts and surgeons around the globe, because we need to operate in very austere environments, as presented here, with tactical medicine doctrine, with limited resources, with very strange and prolonged evacuation. Sometimes it's not armored vehicle, it's just a car, and echelonized care, which can worsen results, worsen functional outcomes. And we need to operate in using very simple techniques and methods and diagnostic tools, as you can see here, just simple ultrasound machine, very simple X-ray machine, and handmade device for compartmental pressure monitoring, etc. But using these techniques in such circumstances, we need to make decision in injuries like you can see here. At the right, for example, you can see that the injury that was attempted to be repaired, and the patient was died a few hours after repair. It also correlates to civilian injuries, as we can see on a regular basis. We we should also treat these patients in our civilian trauma centers. So that's all about decision making. A war surgeon should be a very good, a perfect decision maker first, and techniques and certain skills are the second best. So we need to define whether to perform primary amputation, like for example here in as demonstrated by video, contracture fixed joints, which are the indication for amputation because of irreversible ischemia, or complete or near complete amputation, as you can see on the left side of the slide. Temporary shunting, which is developing, and many publications demonstrated it is effective, it is limb saving, it is life saving. We can use either Pruitt shunts, specific vascular shunts, or just a set of polyurethane tube for infusion. Everything we can on the table of on the surgical set and this surgical table. Another is primary repair. We should be ready not only for placing the shunts and then evacuate patient if the evacuation is somehow limited, or there are no circumstances for evacuation. We should do something to repair, and we should be prepared for repair of brachial artery, femoral artery, and a posterior tibial artery, as presented here on the slides. We should use any supplementary adjunctive maneuvers like fasciotomy on the arm, on the lower leg, which are very important to maintain the blood flow into the peripheral circulation. Also, we should be focused on endovascular surgery, and Professor Todd Rasmussen and Prof. Chuck Fox, who pioneered using endovascular techniques in the war zone. We can use them in two different levels. Simple level, it's just Reboa. Reboa was, to my knowledge, was not very frequent operation during Iraq and Afghanistan war. And also complex, what started from cover filters, from simple embolization, and even like in this video, in this photo, stent graft implantation because of axillary artery injury by their fragment wounds. Again, we need to follow fundamentals, and Mansour Khan will or already describe his book, Fundamentals of Frontline Surgery. Fantastic books, by the way, fantastic book. But we need to be a little bit innovative. And another thing is that our military surgeons, they cannot train themselves as accordingly to maintain the skills, to maintain knowledge and the decision-making process. And this was demonstrated by a recent paper from JAMA Surgery, from our American colleagues. The amount of military general surgeons who are meeting knowledge, skills, and abilities, readiness, they are decreasing in times, as you can see here. And we see the same in our reality, in our civilian and military trauma center. The amount of cases and trauma patients is decreasing over time with the night shift and shift amount of shifts, according to data from our associate professor at our department, is without any trauma patients admitted, is increasing. And as you can see here in a trend, it should be lower and lower in years, and that was confirmed by the COVID pandemic. And now the amount of trauma patients in our trauma center is decreasing. That's why we need to distribute our younger trauma surgeons, military surgeons to different facilities where there is quite a big patients flow with severe traumas. Again, if we can see on these graphs, this demonstrates the knowledge gap among civilian and military trauma surgeons who participated in our trauma surgery workshop. And we can see that neck, so mostly vascular, and vascular are prevailing. And you see that among military surgeons, neck zone of neck, it's most difficult. And this also is confirmed by their will to have certain skills and levels during our course. So they wanted to learn more about neck exploration, vascular exploration, and other procedures during our courses before the start. It's based on two main points. I think this can help to improve their system, to improve patient care, to improve combat casualty care, if you will. The first one is the registry. We know approved registry, prospective observational vascular injury treatment registry about vascular injuries, initiated since 2013 by American Association for the Surgery of Trauma, and now collecting data from 19 institutions, level 1 and 2 trauma centers. Mostly, as I know, most of the patients are civilian, prospectively collected, and you see that almost 5,000 patients already collected into this registry. Fantastic numbers during these years. And what did they prove? They proved that the tourniquet application is becoming more and more popular, even in civilian arena. The temporary intravascular shunts are also used more and more frequently, with very good results, with very early limb salvage and life salvage. And some papers postulated that 23% of stroke rate occur after penetrating carotid injuries from those patients who underwent surgery. No significant difference was found, according to this registry, between vein grafts and synthetic grafts, but they are focused on civilian injuries. I can emphasize on that. And again, increased use of endovascular techniques in preliminary papers demonstrated that 30% of blunt trauma patients underwent any kind of endovascular procedures, which is a very great number. We have these numbers. We in Russia, in Europe, in Asia, we have thousands of cases, but no registries. We need to also summarize our data. We just provided we propose to use this SOST registry. It doesn't correlate with special operations surgical team. It's just an abbreviation of Russian word vascular, which started with SOS, and that's why it is called SOST Vascular Trauma Registry. Why do we do that? To collect data from the real world, from low and middle income countries, to analyze positive and negative experience, to improve vascular care in different countries, and battlefield vascular care, because it's open for battlefield vascular injuries to be submitted to this registry, to improve educational process, and to help frontline surgeons to develop to make decision-making process easily. This is how it looks like. We use admission, discharge, and flow-up checkup blocks to put this in stages. You can see, visiting the website, how it works. The vascular anatomy, we just press on the vessel which was injured, and using this panel, admission, discharge, and follow-up checkup, we can fill in some forms either upon admission or a little bit later, or until or at discharge, and we can also follow up the patients months and years later. This is how it looks like. We use different criteria. Again, we focus on the classifications which are widely used in the world. So you can go there. Your participation should be confirmed. We press just confirm your participation, and you can at least look at it, maybe propose some recommendations, maybe to find some mistakes. We are open for discussion. The second part is education. We organized to promote this vascular trauma care for military surgeons. We organized the SMART educational platform, structured multidisciplinary approach to resuscitation and trauma, as was proposed by me and Mansour Khan. By the way, the first S was very difficult. It is abbreviated a little bit different in Russian, but in English it sounds exactly like this. And we use simulation, as you can see. Professor Samakvalov is trying to control significant massive hemorrhage using virtual reality platform, and we organize the courses in real hospitals here, civilian hospitals in Russia, and for military facilities also. We use live tissue training extensively, and swine, and it is included in all our courses in trauma. The same with cadavers. Cadaver training is crucially important. We create movies, we educate people using modern techniques, using not only surgery but also endovascular procedures, and we use simple orthopedic procedures for military surgeons, like external fixations, and some courses are coming. So the harder you train, the better you'll fight. It was said by Alexander Suvorov, who is the greatest military commander in Russian history, and I think this is the best way to get knowledge, to combine all our efforts to make the care to our combat patients and to improve combat casualty care in whole. So for contacts, for communication, I'm open for discussion. You can use this website, use this email, and please do not hesitate to contact us. We are open for everything. Thank you very much. Thank you again, Amila, for the invitation and ASEAN collaboration for trauma. Thank you very much. Bye now.